Hello, everybody, and welcome to the badEM podcast. My name is Daniel Still, and I'm your host. badEM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. This is episode 4 of season 3, and today I'm delighted to welcome Dr. Edward Chu. He works for Médecins Sans Frontières, or Doctors Without Borders, for a long time as an emergency medicine advisor, now with a slightly different role, but he will tell you more about that. After having attained degrees in anthropology, public health, and then as a specialist emergency physician. Today we are talking about the work that he does, as well as emergency medicine's ever-growing role in global health, and the common ground between the need for urgent care and long-term environmental harm reduction. We draw on his experience in disaster and conflict zones to chat about the skills transfer from humanitarian medicine to everyday emergency care provision in resource-limited settings. We also touch on philanthropy in general and global trends in that space, and then lastly we touch on providing appropriate platforms for foam-made consumers and providers on a global scale, especially coming from the global south. As with all of our episodes, all views are personal and do not represent any organizations that myself nor my guest represent. Without further ado, welcome to the show, Ed. Would you mind starting us off by introducing yourself and giving us a brief background of your professional career so far?
Sure. Thanks a lot, Dan, and it's a real honor to be invited to speak with all of you. I think it is so fantastic that you've created this podcast to be kind of talking about some of these issues with an audience that I think a lot of there is a lot going on in FOAM-Med, free and open access emergency medical education in emergency medicine in particular, but a lot less that we see kind of being done in places like South Africa. So it's a real pleasure to have a chance to talk with you. To answer your question, I had a very roundabout path to getting to where I am today. I started studying cultural anthropology as an undergrad, and then after some work in that, I did a master's in public health and international health with a focus on health systems financing. And then it was only after that I decided to go and study emergency medicine. And frankly, emergency medicine, coming from kind of a public health background, was the last thing I expected to do. I thought I would do community health or something like that, and but found myself really attracted to the kind of perspective that we get in emergency medicine, and so ended up after that really ending up where I am today, and in a trajectory towards global emergency medicine.
Thank you. That is indeed very roundabout, as most of the people I've interviewed and come across generally start more clinical and end up moving towards a global or public health space. And you seem to have gone from one side to the other and then back almost.
Yeah, exactly. I mean, I think what I would say to people who might be considering a non-traditional pathway like this is, just keep looking for opportunities that you find interesting and exciting, and then even if it takes you a while, at least you'll enjoy what you get to do along the way.
And would you mind just elaborating a little bit on your day-to-day role at MSF? I know you worked for a long time as an emergency medicine advisor, and now you have a slightly different job title, as you do spend a lot of time organizing the International Pediatric Days. But would you mind just telling us more about what you do for them?
Sure. So my role has changed a bit recently. So up until this last year, as you mentioned, I was working primarily as an emergency medicine advisor for Médecins Sans Frontières, or Doctors Without Borders, as we translate it. And that's a role in the headquarters in the medical department, where basically for our area of specialty, we try and ensure that the protocols that are being used in our projects that we're supporting, activities that involve, in this case, emergency medicine, and that the protocols, the materials that we have, everything from the guidance that's there to trying to do recruiting and helping to maintain our different specialty pools. All of that is what we are involved in the medical department. More recently, I've stepped back from the direct role of advisor to leading our working group on the topic of emergency medicine, and which we call our intersectional platform. And there, we are going to coordinate more across the organization to make sure that the guidance that we provide across the organization is consistent, that we are also engaging with our other partners in the field, like the WHO, like the International Committee of the Red Cross, for example, and are talking with them as well to try and have at least, if not consistent approaches, we aim for that when it makes sense, at least to make sure that we're aware of what each other's doing and talking across that space. The pediatric days is what I spend most of my time doing right now for MSF. I've also this change has allowed me to go back to doing a lot more clinical emergency care at the bedside as well. But the pediatric days is our main public conference and platform to talk about the challenges that we face in providing care to pediatric patients in humanitarian settings, and to exchange and highlight a lot of the research that's happening in that space. So there's a face-to-face component that happens every year and a half. We just had the last conference in Amman, where the focus was the impact of conflict on children, and as well as there's usually a purely pediatric focus, oftentimes on neonatal care, like it was this last year as well. So we've covered other topics in previous conferences, like challenges of vaccination, the importance of nutritional interventions as well. And one of the other things that I do and focus on between conferences is trying to continue having those conversations, that exchange in the digital space. So we've just had our last webinar on GastroSam, which was a really important research project on rehydrating sick and malnourished kids in low resource settings. I think that's probably going to have a big impact on our practice coming up, and then we tackle other topics that we bring up during the conference, and try and keep those conversations and give them more space in a webinar format. So this next month, we're going to be talking about the importance of play and how critical that is in providing humanitarian care as well.
That certainly sounds like enough to keep you busy. And who is the main target of the content that you put out in either a live or digital format? Is it the people that work for MSF itself? You mentioned also the ongoing collaboration with the WHO and International Society of the Red Cross. Is that to try and get the whole humanitarian emergency medicine world following the same protocols, so to speak?
So in terms of coordinating, yes, I think one a very concrete example is we have been developing with WHO and the ICRC a common triage tool for routine triage. So that's something that we end up as you all know, is a critical part of providing emergency care, and recognizing that staff, especially in field projects, they may be working for MSF one year and working with the Red Cross another. They might end up working in a WHO supported project, and so we felt there was a real important benefit to having a common approach to triage. So coming up with a common tool that we could all agree with is challenging. It took a lot of negotiation and discussion back and forth. And if you see the tool, you can search for the integrated interagency triage tool online or on the WHO website. There's certainly things that especially emergency physicians can criticize about it, but our goal was really to have a common tool that staff could use and reference regardless of where they end up working. And as we all know, it takes time to learn these. If we could have a consistent tool, then that can hopefully help in the acquisition and practice of that. So there are examples like that where we really feel that there's work that's so consistent across what the organizations are doing that we really want to try and find a common tool that we can all use. More often, it's being aware of how others are working. We may be, because of the resources that we have, because of the specific context that we're working in, or for other reasons, we may take a different approach, but at least we want to make sure that we're doing that with an awareness of what the current WHO recommendations are, or what other agencies, organizations are doing, that may be in a similar context.
I feel like one of the recurring themes amongst many of my guests is the lack of consistency, even within microsystems. Sort of two hospitals, even in the same neighborhood, sometimes do things completely differently, which does often lead to communication breakdowns. So to coordinate global protocols across many settings, I take my hat off. That seems like quite a task.
Absolutely. No, it is. And I should say my views are my own and based on my own experience as far as what I'm representing today. But it is, I think, as you were saying, even from hospital to hospital, that can be, extremely confusing and challenging. And you can imagine when, there's an emergency, there's a bunch of different organizations, public, private, that are, descending on a particular country or community, and everyone has their different approach. That can really be, crazy making for staff that are trying to respond for the local health system.
And then to move on, drawing on your experience and training in both emergency medicine and global health, emergency medicine is a relatively new speciality in comparison with others. And in some places, especially in an African settings, it's still in its infancy almost, and in some settings doesn't even exist. And in the global health arena, it is also very new. And they've been having conversations and policy making events for decades without much emergency medicine input. So where do you see emergency medicine fitting into the global health arena at this point and as it grows?
So I think it's a really exciting time to be an emergency medicine provider, I think, in the global in global health. There is developing in the last 5 to 7 years. There's really been a big increase in the appreciation for emergency medicine. It's still relatively new, like you were saying. There's a lot of advocacy that we need to do. I would say there's we can answer that. I can answer that question from two perspectives. As individual providers, it's really exciting because the competencies that we bring to this kind of work, I think, really make us uniquely adapted and useful in those settings. So, we're used to making decisions in uncertainty, right? Not having all of the information, and really, I think, we talk a lot about pretest probabilities, about kind of Bayesian decision making, and that is not something that everyone is used to thinking about, thinking in probabilities, in uncertainty. And I think that really helps us to be adapted to a lot of global health work where you're having to make decisions with limited information, even fewer resources, and from a very concrete perspective for clinical care, fewer tests, fewer studies that you might be used to having. I think the other thing that we learn is we talk to everyone as emergency doctors, right? We talk to the consultants. We're constantly talking and working, I think, much more closely than in many other parts of the hospital with nurses, with auxiliary, and with our techs, because of the nature of how we have to get things done in the emergency department. So I think we gain an appreciation for what our other kind of paramedical staff are doing, and then we also learn to talk to patients, all different kinds of patients, the ones that are easy to work with, the ones that are challenging, and their families in incredibly stressful situations. And so all of that really gives us the ability to be excellent managers, to step out of our clinical role when we're in the field, and be able to talk with all different kinds of people, whether that's counterparts in other NGOs that have other roles, with non-clinicians, with all the different type of people that we may need to communicate with in the humanitarian settings. And we're resourceful, right? We don't get to turn off the lights and close the doors because the X-ray machine is down today, or because we ran out of chest tubes, for example. And so that kind of resourcefulness, the attitude of, okay, I have a patient in front of me, what do we have? And how can we make that work to take care of them, is extremely, extremely useful when we're in the field. And I think maybe more from a systems perspective, I think, we don't always necessarily appreciate this as emergency providers, but, we are oftentimes the safety net providers. Our position in the emergency department as safety net providers gives us an opportunity to really see the effects that the healthcare system as a whole, oftentimes, we end up being the canary in the coal mine. When people are losing their jobs, they end up in the emergency department. If they're losing access to their primary care providers, we often say we're everybody's primary care doctor after 5 p.m. and on the weekends,
and sometimes even within normal working hours during the week, to be honest.
Exactly. So, depending on the healthcare system, we may be people's first point of primary care if they rely on people being insured. So it does give us the opportunity, if we're paying attention, if we're looking to see those aspects, to see the impact of other broader policy decisions on the healthcare system, right? The availability of hospital beds, when they're, the availability of inpatient psychiatric care, which in a lot of settings, right, there's much less access to mental health. And so we see those patients in the emergency department. So it really does, whether we like it or not, put us at a really fundamental point in the healthcare system, and gives us a view on what the gaps are in healthcare, because we often are the ones, the provider of last resort when gaps exist.
I like the metaphor with the canary in the coal mine, but a canary in the coal mine is only really useful if somebody listens to the warning signs that it's giving. So, I think, like you say, the advocacy is hugely important to getting emergency medicine at the table where these decisions and discussions are being made or being had.
Exactly. I mean, I think that is so important, which I think I gained an appreciation for, having done public health before. I think as clinicians, there's this sense that the advocacy and what you have to do to get a seat at the table, oftentimes, right, that's kind of the less pure aspect of medicine, and it's getting your hands dirty, but it's so important. If we want to have an influence, if we want people to listen to our experience, then, as you said, we have to have a seat at the table. We have to advocate to get that seat at the table. Oftentimes, that so often that's not going to be handed to us. We have to demand it and try and get there.
So moving on with the same theme, with emergency medicine or even clinical medicine in general, there seems to be a dichotomy between problems that are urgent or currently sitting on your doorstep, things that you have to do today, and the bigger picture of long-term drivers of health and the reasons that people are actually presenting to hospitals, which often stems from their lived environment and long-term socioeconomic issues. And we know about these causes. The clinicians recognize these issues, but we don't have the capacity to act on it at the time. And then in contrast, you've got your public health professionals and organizations who are often addressing these issues, but they are very long-term projects that often take years to show results and materialize. And that's due to their nature. That's not avoidable. But I feel like unless there's a conflict or another humanitarian crisis where you have a direct causal nature of an externality causing people's healthcare issues, there's not much direct overlap between the public health and the frontline work, with, I feel, not many people solving the medium term, in quotation mark, problems. I don't know if that makes sense.
Yes, I think it does. And what I would encourage us to think about is the opportunities that we do have in our own practice environment to address some of these systemic issues. And there are things that we can do. In fact, sometimes they feel like a burden because they come down as requirements from on high. But I think appreciating our place in the healthcare system, especially if it's a healthcare system under stress or in crisis, can help for those to be seen, for us to see those as opportunities. So there's we're used to an emergency medicine asking patients about their tetanus status with injuries, taking that opportunity to update their immunization. We can do that for other things besides tetanus, of course, right? And so there are opportunities to address gaps in vaccination in the emergency department. I think oftentimes patients are coming to us, as you mentioned, with issues that we can't necessarily address, right? Things that are beyond our control in the emergency department, socioeconomic issues around health literacy. But that is one of the things that, as providers, I find really motivating and helps me avoid feeling like, there's nothing I can do when a patient comes and really what seems to me like the biggest issue are issues of access to care or health literacy. There isn't necessarily a pill I can offer them, maybe because of lack of access to healthcare. Even if there is a medical solution, that may be out of that patient's reach. So maybe I can provide them some education about their condition so that they can be more aware of how they can take care of that as best they can in a system with a lot of limitations. And of course, there's the opportunities beyond the bedside that we have. We were just talking about advocacy. I think we had an opportunity. We invited a surgeon from Cape Town, Sebastian Van Ass, from the Red Cross Hospital, and he talked about one of this really amazing intervention that a program that he had started with cab drivers and rewarding them for safe driving and the huge impact that had on decreasing injury for kids. So I think there's there's definitely big things that we can do away from the bedside, like that. But there's a lot of things that we can do in our regular day-to-day work in the emergency department. Screening for STDs and things that do have an impact and that can address some of the issues that we face that are more systemic in nature.
And obviously, in the nature of our work, we don't often get to see the outcomes of our interventions. So we might be actually doing more than we think we are with these type of small interactions.
I think as providers, that can also, oftentimes we end up feeling like our hands are tied, like there's nothing that we can do to, address some of the problems that patients are feeling. And, being able to provide something, even if it's education, for us as clinicians, it may feel like we're providing less, but sometimes that can make as important an impact on a patient. And I think, for us in terms of longevity, at least, it avoids us feeling like our, there's nothing that we can do, and the whole system is, preventing us from being able to help our patients.
And yeah, I think even a perception of doing good can help a lot with our own sense of job satisfaction and longevity.
Exactly. We have to learn to be nicer, kinder to ourselves.
So I know you've worked in numerous conflict environments. For example, you were in Gaza, and prior to that, you were in the Ukraine after Russia invaded. And these are both fairly drastic examples of working in resource-limited settings. Are there any lessons that you can take from these situations and apply them to a more chronically resource-constrained setting where there's a longer-term supply versus demand problem?
Yeah, absolutely. I think there's a lot that's hard to translate, but there are definitely, I think the most important thing that you learn working in those settings that directly translates to our work in the emergency department, wherever we happen to be, is how important the other roles are of people in the team that's part of the whole healthcare team. And especially in those kind of settings, I think what you learn to appreciate that we often take for granted in our own settings is the importance of logistics. And that is one of those roles that you can't do anything when you're in a conflict or in a humanitarian emergency without logistics, without the material and the resources. And even if we do have access to more from a pure logistics perspective, I think you do appreciating all of the different roles that it takes to provide healthcare does really translate well to the emergency department, whether that's working with our nursing colleagues to come up with protocols that can help us to either provide better care or provide smoother care, have the medications in the way that we can use them best at the bedside. There's a lot of roles that can help us in doing that. Our pharmacists in making that kind of change in an emergency department setting. I think there's from a conceptual model as well, very practically speaking, there's this ER specialist, Scott Weingart, who has an amazing podcast called MCRIT. And I was just hearing him talk at the Incrementum conference in Spain. And he was talking about, I hope I'm paraphrasing him correctly, but he was talking about being a resuscitation logistician, right? This is one of the things that he emphasizes so much is understanding what's needed to, efficiently put a central line in, how to manage complicated airways, and the actual materials and the things that are needed in order to be able to do that, quickly and efficiently at the bedside. And it's it's such a great example of how we organize things having a huge impact on how we provide clinical care. We do that a lot in organizations like MSF when emergency kits come and everything's prepackaged and you have what you need. And taking that same approach to what's in your crash cart, what's in your trauma bay, can make a huge difference in being able to, be able to provide, especially critical procedures, in an efficient way. Logistics is one of those things you don't notice it when it's working, but when there's a step that fails, boy, you learn to appreciate it.
Yeah, I think in our training, the clinical procedures are often focused on, but far too often it does happen when the logistics fail and you have to do something differently. So it's good to recognize that. And then moving on to humanitarian work and philanthropy, which is very diverse in of itself and cannot be all clumped together to start with. And it is also a very dynamic area, especially over the last year or so with the geopolitical landscape we are living in. There is a trend, however, towards a just giving or no strings attached money to local projects, with the risk of money being misspent and the outcomes often not being as measurable. But the thought is that this is deemed less counterproductive than too much money being spent on needs assessments and supporting humanitarian workers themselves, with a smaller proportion of the total cost going towards the desired outcome. So, what are your thoughts regarding this trend in philanthropy and the relationship between benefactors and beneficiaries?
So, I think this, especially on this topic, I'll emphasize that this is one. It's an incredibly complex topic and one that does go a bit outside of my personal experience and my area of expertise. So you can take these thoughts as with that in mind. From a philanthropy perspective, I think in larger philanthropies, and I think that has been a very positive development. When the thinking of a charity and charitable work, and so where one is providing care that the charity mindset of something is better than nothing. People are lucky to get what's being offered. Thankfully, I think for the most part, and especially with larger, I think philanthropies or humanitarian organizations, we've moved well away from that perspective. But it's still out there. You run into it from time to time. So we have to be very aware that we are providing care in a context, providing care to patients, regardless of whether they have the right to pay, that patients, whoever they are, have a right to quality healthcare, to expect things from their providers. And MSF has a patient charter. I think that is all of these are very positive developments and an evolution away from that turn of the century mindset of charities being something that people are lucky to be receiving, and so forth. There's also the perspective, the folks who argue that what's really needed is work and jobs, and people, if they could have that, they would much rather be able to have the economic resources to pay for the healthcare that they need. And I think that's also a very valid judgment. And there's criticism, in when we study public health about this whole aspect of humanitarian medicine, and is that both genuinely helpful? Is it how helpful is that versus funding development, or even there are folks that argue that kind of funding just props up governments that are not providing the services that they should to their patients, and so there's negative impacts of that as well. So I think it is very complicated. There's arguments that you can make from many different perspectives. I think the most important positive trends are that, regardless of whether it's philanthropic, whether it's development work in other settings, making sure that what you're doing, you're having an eye towards sustainability, that you are focusing on what it is that the patient or the health system's needs are versus, there's a lot of volunteerism that also kind of happens out there. And, if you're getting more out of it than what you're putting in, you may have to check and make sure that how much of a benefit is that having towards the patients and the health system that you're intervening in. The trend towards recognizing and putting greater emphasis on patients not as passive recipients of aid, but as having rights regardless of whether that's aid or care that they are paying for, that they have the same right to high quality healthcare, oftentimes constrained by the resources available in a particular context, but still recognizing that importance, I think is a very positive trend. I don't know if I answered your question, but it is a really thorny question, and I think there's, from all the critiques, there are legitimate elements to those, and there's certainly lots to criticize. I think we also see when that aid is taken away, it can have a very negative effect as well, and unfortunately, we're seeing the impact of that as well.
And then the last question from my side: if you had a magic wand and you could materialize anything in global emergency medicine overnight, what would that be?
Well, aside from having unlimited resources to provide healthcare, I would have FOAMmed kind of leapfrog 10 years into the future and be widely available. I think the free and open access medical education movement, what that did for emergency medicine in high resource settings, it really did, I think, shift the center of gravity in our field from academic institutions or the major kind of edited publications being the gatekeepers for knowledge in our field, to shifting that to the ER docs working in communities, working in emergency departments that just had really good insights, knowledge to share, or particularly good teachers. And that's had a huge impact for emergency medicine as a specialty. But the potential for that in developing health systems in the developing world in lower resource settings, I think is enormous, because they're even more so, it's harder to access the traditional providers of emergency education and knowledge. There are fewer academic centers. They're harder for people to reach if you're in a really low resource settings. People are facing all kinds of challenges. There's conflict and unrest that closes the medical faculty where you are for months or years. The challenges in accessing face-to-face education in an academic setting, I think particularly in low resource settings, is enormous. And so the potential to make that knowledge easier to reach, and also to give a platform to providers that are coming from those settings, right? There's so much, one of the challenges that we face in trying to translate high resource setting research and things that may work in a well-resourced health system that just does not translate to low resource settings. What we're missing is those voices and experience of providers that are in low resource settings that have found ways to make things work in that context, to be sharing that with their colleagues. And so, I think if there was one thing that we could do that would make a huge impact in humanitarian medicine, would be to have that kind of platform, to have that kind of reach and communication, to learn from each other. And I think that's what makes this kind of thing, this discussion, so exciting. And we need more of these platforms. We need to mature the FOAMed kind of field for humanitarian medicine.
I agree. I think a big jump in the access to context-specific FOAMed would be massive for global emergency medicine. Before I let you go, is there anything else that you would like to touch on or expand on?
So, I think what I would also want to highlight is what an exciting time this is for emergency medicine in global health. We're finally, there's a growing recognition of the importance of access to emergency care. This really got thrown into relief during COVID, and both at the WHO level, with kind of an orientation towards the continuum of care, including emergency medicine as an essential part of universal health care. Within a lot of the larger NGOs, this kind of recognition that patients have, acute conditions start with the patient in the community. They don't become an acute condition when the patient crosses into the emergency department or gets admitted into the hospital. It's like you said at the beginning, emergency medicine is new. Its relevance to this work is starting to get recognized. And so because of that, it's a really exciting time. The guidance globally on mass casualty management, for example, that's just some work that WHO has put out very recently. All of this is really being developed today as we speak, and so there's going to be, I think, more and more opportunities, more and more interesting opportunities for folks in our field who are interested in global health, who want to get involved. Yeah, I think it's just a really exciting time to be doing this.
Wonderful. Thank you so much for your time and your insights, and it's been lovely chatting to you.
Right. Thanks a lot, Dan. And thanks so much for this opportunity.
So that brings us to the end of the episode, and a huge thank you to Dr. Edward Chu for joining us today. From his fascinating professional path through anthropology and public health, and then frontline work as an emergency physician and humanitarian worker, we have covered the expanding role of emergency medicine in global health, the overlap between urgent care and long-term environmental harm reduction, and what humanitarian medicine and disaster medicine from conflict zones can teach us about everyday care in resource-limited settings. We also touched on broader philanthropic trends and the importance of building platforms that serve FOAMed consumers and providers worldwide, particularly voices from the global south. We hope that you found this as thought-provoking as we did, and be sure to rate, review, and subscribe on your favorite platforms, and share the podcast with a friend or colleague who might be interested. If you would like to get in touch, find me on LinkedIn or email me at dan@badem.co.za, or follow us on Instagram and Facebook at Brave African Discussions, or X or Blue Sky as badEM. Thanks for listening. See you next time. Bye bye.